And so we will move on into how do we look at this morning. I think we talked about GLP-1 and GIP, but that is a coming attraction. But what we have right away is GLP-1. So just to tell you that if we can afford 4,000 crore weddings, 5,000. I'm sorry, I stand corrected. There was another joke about it that the bride's father has 755 and the groom's father has 7,65,000 crores. Okay, so this is called the poor girl making it big by marrying a rich guy. So with that, let's talk about oral semaglutide, right? So very, very interesting to remember. I always look at this as something very interesting because the original work on oxytocin was the work and then desmopressin was the work that preceded insulin because we were able to understand how to engineer proteins because they're very small molecules. So when they first talked about semaglutide, they said it's the first peptide in a pill, and I said no, it's not. Right? Minerin is the first peptide in a pill. But we've learned so much from proteins, and putting proteins and making it orally available is actually a miracle because proteins are meant to be destroyed in the stomach, right? And that's really what happens. So let's talk about this. We talk about the Pioneer program, we talk about oral semaglutide, we talk about this thing. Right. So this morning I didn't have the opportunity to show this to you, show the amino acids to you, but this is the native human GLP-1, right? The first way, there are two things that happen to GLP-1. The GLP-1, how does it work? It works by stimulating, by making the pancreas secrete more insulin. That's the simplest way it works. And then it works in the brain, and I told you that the GI side effects are predominantly because of the brain, not because of the slowing down of the GI tract. That's why GIP does not reduce the nausea when combined with GLP. Right? Then how do you extend its action? You can extend its action. The first way to extend its action is to prevent it from getting degraded by the enzymes that is present in our body. And once you do that, then you can do several things. You can add a protein to it, you can add a fatty acid to it, that extends its action. So you will find that because these are proteins, all of these are parenteral, subcutaneous. Now extending the action is easy because the greater the tolerance, the slower the action, the slower the degradation, right? And Novo has pretty much used the fatty acids, the C18, the C16 and higher fatty acids to extend the action. So now we have weekly, which is dulaglutide, and see the difference. This is using a protein, therefore the weight is so high, 59 kilodaltons, but semaglutide is 4 kilodaltons. Advantage, this gets into the brain easier. This doesn't cross the blood-brain barrier so well. That's why you see the difference between dulaglutide and semaglutide in both the weight as well as the actions. This came from Lira. On this side you have extended, which is the Gila monster. Everybody talks about the saliva of the Gila monster is non-degradable. And then we had lixisenatide, exenatide, lixisenatide. Today we heard lixisenatide plus insulin, which is solicide. But converting this to an oral tablet is a challenge. Is the piece de resistance because you can have your cake and eat it too. You want the benefit of a protein, at the same time to be able to take it orally is a challenge. And I remember the discussion that really happened was should we get oral into India first or the injectable to India first? And I was part of the discussion, and at that time, remember 10 years ago when these discussions started, 8 years ago, The acceptability of injectables are still fairly low, but now today the acceptability of injectables is much, much higher. But I think it's a bold move that Novo made, and it's paid off. So remember semaglutide, it's 94% analogous to human GLP-1. And this is a thing that you will find constantly in every disease. This amino acid substitution at point 8, which is the AIV, right? This provides DPP-4 degradation. You'll find a similarity here in almost any GLP-1 RA. Then this fat comes here, right, at 16. Now, normally what will happen is protein will get bunched up. Prevented from getting bunched up, only the right place is to be attached. This arginine is there. This is all, it is a simple Sanger sequencing and increasing this thing, right? Sanger sequencing, because William Sanger, the man who described insulin, described how to sequence it. Now, how do you make it absorb? So you add something that will create an area around the molecule in the stomach through which this can go into the mucosa. That is what is basically doing is, there's a forest, right? You go into the forest, it's quite possible something may jump at you and eat you. That's exactly how it works. So how do you go into the forest? You make a small clearing. You send somebody ahead, you clear the area, go in. That's how they did it, right? So this snack, which is sodium N82-hydrobenzoyl aminocaptide, or you can think of mixture and glucose and just call it a snack. So what it does is, it clears the area around the mucosa for the drug to be absorbed. And when it does that, it goes inside. Once it goes inside, it behaves exactly like injectable semaglutide. So all that oral semaglutide is doing is, when you give it, there is a small place created in the stomach where it can be absorbed, it goes inside. So all we are doing is to prevent it from being degraded in the stomach. Now there are 2 or 3 things that you want to remember. For example, we have 3, 7 and 14, right? I'll say it right away and won't go later. The amount of snack that is required has to be exact. For example, if you break the tablet, it won't work. Let us say you're moving the patient from the 3 to 7 milligrams. And you say, no, doctor, I have supply of 3, can I take 2? It won't work. Because you're doubling the amount of snack, it will cause to lesser absorption. Because even when you use the snack, it's a very, very small portion of the molecule that gets absorbed, right? So this is something you want to be very clear. So tell patients, by the exact amount, come to me on the same day, on the day that you're supposed to come. When I increase the dose, you finish the tablets and then go to the next dose. Don't take double or triple. That's something you want to do this. So this is a snack. It's a co-formulation. It's a small fatty acid absorbent. It promotes absorption across the gastric epithelium. And every semaglutide, whether it's 3, 7, 14, 28, or the 50 milligrams that people are talking about, all have only 300 milligrams of snack. If you use 600 milligrams, it's not absorbed. So be very clear about this. I told you this. So remember that even with all this, only 1% of the semaglutide is absorbed. But that 1% is absorbed, it becomes equivalent. Once it gets into the blood, it's the same as having given it subcutaneously. So everyone's clear about this? So let's move on and let's talk about the Pioneer program. I won't spend too much time on it. The Pioneer is a program that looked at whether oral semaglutide will do the same things that subcutaneous semaglutide does. 1 versus placebo, 2 versus SGLT, DPP-4, GLP-1 RA, and dose adjustment. 8 is insulin, 5 is renal impairment, and 6 is CV safety. Remember, the Pioneer 6 was an underpowered study for CV safety. It met its primary endpoint of non-inferiority. but did not show superiority in it. And therefore, but remember that other studies like the SELECT, any of the subcutaneous, this thing, we know that is superior. And even in obesity now we have cardiovascular safety, but if somebody tells you, okay, is this superior? We don't have data, we have to wait for the SOUL study. So we must remember that. Now, I want you to forget this morning's talk, not 2.6 or 2.4, 1.5 at 14 milligrams. It's still tremendous. No drug in the market today, other than insulin, gets this. At very, very high doses of sulfonylureas, at very, very high A1Cs you do it, but let's say you have an A1C of 8, getting to 7 or 6.8, none of the drugs can do it on monotherapy, right? That's tremendous. And what is the difference? Can you see this? The difference between this and empagliflozin. This is sitagliptin. This is liraglutide. And remember that liraglutide is not 1.2, it's 1.8 milligrams. I know for some reason many people in India still use 1.2. I always use 1.8, and that's the right dose. So this is significant improvement because the next one, in renal. And this is where I think the GLP-1 RAs are a godsend for in renal because one, they don't really have a greater amount of hypoglycemia. We now know from the flow study that they're renal protective. And they help you reach A1Cs that are good without adding insulin. And with insulin, you will see that it reduces the A1C, it is superior, and also that the dose of insulin comes down. Now, what is even more important, and this is something that you will notice from the GLP-1 RAs forever. JJ is here, Rajiv is here, other colleagues are here, and you remember that prior to 2005, you will not find a single study, and if you show it to me, please, I'm happy to be corrected. I've been saying this in many places. You will not find a single study where greater than 50% of patients in any study have achieved an A1C of less than 7. You can search the literature, you won't find it. Getting A1Cs of less than 7 in more than 50% of the study population is a pure GLP-1 RA phenomenon. This is not being found at many others. When you look at this, you're looking at patients who are reaching 80% A1C less than 7 at the end of this year. It's pioneer 1, pioneer 2, pioneer 3, and this is really very interesting stuff. And you'll find that many of your patients, as you give these medications, you'll find A1Cs of 5.8. Not 6.5, 5.8. You're almost thinking, are they in remission? I remember asking John Hughes, are we putting these patients in remission? And he laughed at me. But this is really the question that you're asking. We're getting 5.6. I was a little worried when people said it's 4.3 4.3 is the predictor for GDM, but this is something very interesting. So this is the weight reduction. At monotherapy 4.1, 4.7, 5. But what you're seeing is actual weight at overall 3.5. But many of our patients actually do significantly higher weight reduction. And especially in combination with an SGLT2 inhibitor, they do even better. And I find that many of our patients end up doing 12, 14% absolute weight reduction at 14 milligrams. So this is the percentage that received greater than 5%. In the Indians, I'm sure you'll find much better. And of course, we know that, I already talked about pioneer 6. Just to remember that it is non-inferior, it doesn't worsen cardiovascular risk, it's cardiovascular safe. Whether it protects for CV risk, we will know once the SOUL study. But as a class effect, most of us think that it works. Alright, let's look at other stuff. So, it's once a day, we talked about that. reduces waist circumference, so it reduces intra-abdominal fat. The other important thing, remember when you take here is where we want to we understand. When I talk about its action in the brain, its action in the brain is very, very important because we're talking about its action on what happens in the hypothalamus. One, in diabetes itself, there's inflammation that is occurring in the hypothalamus, right? That's why diabetics crave food. There's a balance between orexogenic and anorexogenic peptides. Orexogenic makes you eat, anorexogenic peptides makes you eat. So there are receptors for GLP-1 in the POMC, pro-opioid CART receptors, where these work. And therefore they reduce the appetite. Why is this important? If you take an SGLT2 inhibitor, you will realize that what it does is it drives glucose into the urine, right? And Ferrini and his daughter both did this amazing study where they showed that after some time the body readjusts and makes you want to eat more. That's why after some time the weight plateaus, one of the reasons the weight plateaus, and then you will find the caloric intake increase. But with the GLP-1RA, because they work predominantly at the brain, this phenomenon is not there. Therefore, you actually crave less food. In fact, I've heard people who say that, look, doctor, I don't feel like eating much. And in fact, if they hate anything about the GLP-1RA, it's that, doctor, I don't feel like eating. The worst I've heard is, it's like having green tea, doctor. That's the feeling I've had the whole day. You will lose a little, you will get a little intolerant for salty food. I don't know if you noticed that, but these are part of it. Reduces systolic blood pressure, I don't want to get into this. Improves blood lipids, reduces inflammation. You lose weight, you get inflammatory problems. Right? So what do we have here? So, one, somebody asked, I think sir asked me this question this morning, and I said, we talked about couples. I think these are made for each other. Even Nock calls it as a marriage made in heaven. The GLP-1RA with an SGLT2 inhibitor have very, very effects. One, the heart failure, predominant effect of an SGLT2, the cardiovascular predominant effect of GLP-1RA. The effect on appetite, the effect on glucose, correct? The combined effect on weight, and we use a lot of 300 milligrams of canagliflozin along with the GLP-1RA in patients that we want weight loss, and works like a charm, absolutely works like a charm. Right, so we address all of these. This is a SOUL trial that is going to come. It's 9,600 patients. How do you take it? It's about 5 years, looking at 1,225 events. When that happens, we will know whether it's cardiovascular superior, but till then we are fine. This is a pioneer India study. Many of us, including us, and there was part of it that's looking at the real world evidence for India. We're also looking at a new study that initiated that is looking at early use of semaglutide in clinical practice. Why am I talking about early use? But I think this morning I've talked about it in many places. I think there's a shift in the management of diabetes. My current algorithm for diabetes is one, if there is a compelling comorbidity that requires a drug, patient is motivated for remission, then offer it to the patient. Don't give it to a pseudo nutritionist who's going to run. You do it. Third, if the patient will benefit from weight loss, the majority of the patients, remember the Retune study, even patients with a normal BMI benefited weight loss. So don't think that a GLP-1RA is only a weight loss medication. No, it is the primary therapy of diabetes needs to shift from glucose control to reducing weight. You lose up to 10 kg. And remember, you don't have to say 3, 5, 10. It's a continuum. The greater the weight, and JJ showed that beautifully. The greater the weight loss, the greater the benefit. It's a continuum of benefit. And then if there are special situations, we address it. But weight loss needs to become the primary therapy of diabetes. I'm going to stop here. I think we have 5 more minutes, but we can make it up and take it in the discussion. Rajiv, you're going to talk about how to take the drug, right? Okay, so Rajiv will do that. Thank you so much. I really appreciate this wonderful crowd. Every time I come to Trivandrum, I'm so happy. As much as happy as I'm here to see Padmanabhan. So thank you so much.